Next chapter is about stomach. Anatomy and physiology of stomach. Parts of the stomach. So this is fundus. This is body, and this is antrum. The thing dividing the body or corpus and antrum is incisura angularis. And the dividing fundus and body is gastroesophageal sphincter. So first let's talk about fundus. The fundus is located above the gastroesophageal sphincter. What are the glands present here is called fundy glands. The cells present here are enterochromaffin like cells, mucus cells, and endocrine cells. You can remember it as EME. E for enterochromaffin like cells, M for mucous cells, and E for endocrine cells. So what it secretes? Enterochromaffin like cells secretes histamine. Next we'll talk about body or corpus. The body or corpus is located between gastroesophageal sphincter and incisura angularis. The glands present is oxyntic glands. Cells are parietal cells, chief cells, and mucosal cells and enterochromaffin like cells. You can remember it as PCEM. P for parietal cells, C for chief cells, C for enterochromaffin cells, M for mucus cells. What these secrete? The parietal cells secrete acid and intrinsic factor, and chief cell secretes pepsinogen. And let's talk about the structure of oxyntic cells. The oxyntic gland, it is present in the body or corpus. It has mucous neck cells, parietal cells at the neck, and enterochromaffin like cells at the base, at near or just above the base, chief cell at the lowermost part of the base. Let's talk about antrum. The antrum part is located below the incisura angularis. The glands present are pyloric glands, G cells, mucosal cells, and enterochromaffin like cells. You can remember it as PGME. These G cells secrete gastrin. Next, let's talk about fundus. We already talked about fundus. So that's it about the parts of the stomach and the glands and their secretion. Layers of gastroduodenal mucosal defense. There are 3 layers: pre-epithelial layers, epithelial layers, subepithelial layers. The protective factors are COX-1, cyclooxygenase 1, which secretes prostaglandins in the epithelial layer. Damaging factors are acids, NSAIDs, tobacco, and H. pylori. Layers of GIT. Mucosa. It contains mucosal gel coating, epithelial layer, lamina propria, and muscularis mucosa. So it contains mucosal gel coating, epithelial layer, lamina propria, and muscularis mucosa. Submucosa contains Meissner's plexus. Muscularis contains outer longitudinal and inner circular, and in between you have Orbach's plexus. And then serosa. What is pacemaker cells of GIT? It is a interstitial cells of pacemaker cells of GIT are also called as interstitial cells of Kajal, which produce the basal electrical rhythm. The enteric nervous system has 2 parts: intrinsic innervation, extrinsic innervation. The intrinsic innervation is Orbach's plexus, which controls motility. The Orbach's plexus is present between the outer longitudinal and inner circular muscular layers in muscularis mucosa. And Meissner's plexus control intestinal secretion. Meissner's plexus is present in submucosa. Extrinsic innervations is autonomic nervous system, which contains Sympathetic activity which decreases the motility, parasympathetic which increases the motility. Cooperative synergism. Enterochromaffin like cells secrete histamine which increases the cyclic AMP causing increased acid production. G cell produce gastrin which stimulates the CCKB receptors in the parietal cells and increases the acid production. Acetylcholine stimulates M3 receptors and which increases the calcium level which causes increased acid production. GRP gastrin releasing peptide or bombacin which increase acid secretion. Inhibition of the acid production. Inhibitors of the acid productions are CCK cholecystokinin, prostaglandins, somatostatin, gastric inhibitory peptide. Basal acid output. Maximal acid output is during 6 pm. Least acid output is during 6 am. So the ratio between BAO and MAO should be more than 0.6. If it is more than 0.6, then you have a gastric secreting tumor. Let's talk about gastritis. It is mainly of two types, the acute phlegomonas gastritis and chronic gastritis. Acute phlegomonas gastritis, it is rare and severely progressive inflammation of the gastric wall, thickening of the wall and gas formation. Where it is seen? It is mainly seen in the immunocompromised people. What is the causative agent? Causative agent is streptococci more than E. coli. Clinical features is abdominal pain, vomit and fever. Complications is stomach wall necrosis which increases the motility rate. Note: the eosinophilic gastritis causes intestinal obstruction. Russell body gastritis causes pseudotumor endoscopy appearance. Granulomatous gastritis causes chronic disease which is most common cause. Lymphocytic gastritis causes celiac disease. Chronic gastritis. It is a superficial involvement of lymphocytes and plasma cells. There are of two types of chronic gastritis. Type A, which has high risk of malignancy. Type B, which has less risk of malignancy. Type A, it is very less common. Type B is more common. Type A is also known as autoimmune metaplastic atrophic gastritis, AMAG. Autoimmune metaplastic atrophic gastritis. Type B, it is also called as environmental metaplastic atrophic gastritis, EMAG, AMAG and EMAG. EMAG means environmental metaplastic atrophic gastritis. What is the pattern of atrophy? In type A, it is patchy, mainly in corpus, that is body. Type B is multifocal. What is the cause in type A? It is autoimmune, that is the HLA-DR3 or B8. In type B, it is H. pylori. The complications in type A is antibody against parietal cells, decreases the acid secretion, causes achlorhydria, then hypergastrinemia, causing gastrin secreting carcinoid tumor. Antibody against parietal cell also causes decreased intrinsic factor which causes megaloblastic anemia. And in type B, the complications are the gastritis causes gastric atrophy which causes intestinal metaplasia and gastric adenocarcinoma and gastric adenocarcinoma at end. What is a histological inflammation of gastric carcinoma? It is mainly caused by NSAIDs more than infection. The diagnosis is clinical or endoscopy and histology. Actually, the endoscopy and histology is not required. Can clinically diagnose it. So next topic is hypertrophic gastritis. In hypertrophic gastritis, which is also known as Many disease or protein losing gastropathy. It involves body and fundus, and it spares the antrum. There will be large tortuous mucosal folds inside the stomach. It is most common in males compared to females. 40 to 60 years age, children are more prone to hypertrophic. Children who are prone to this hypertrophic gastritis are mostly associated with cytomegalovirus infection. The clinical features associated with the hypertrophic gastritis are hypoalbuminemia, edema, and upper GI symptoms. The pathogenesis are main cytokine is tumor growth factor alpha, foveolar hyperplasia causes hypersecretion of mucus, and there will be protein loss. Investigation is through endoscopy. Full thickness biopsy should be done as per the malignancy. The treatment should be surgical. Main treatment should be surgical. Medical treatment should be EGFR endo antagonist, that is cetuximab. Epithelial growth factor receptor antagonist, which is cetuximab. Next, let's talk about H. pylori. So H. pylori, as you know, it is a gram-negative bacilli. The triple positive test are urease test, which helps urease positive. The urease present in it helps to reside in the stomach. It is catalase positive and oxidase positive. Urease catalased and oxidase positive. It is present mainly in the antrum region, and it can migrate proximally due to the flagella, but it is not invasive. It resides in the deep mucosal gel. The pathology behind H. pylori is it is transmitted through feco-oral route. The colonization depends on socio-economic factors. If progression is due to colonized population, 80% of the developing countries, usually 100%. Majority it causes chronic superficial gastritis and 10% peptic ulcer. The enzyme produced by it is urease and protease. The urease creates alkaline environment. Protease digests the mucin. It's protective against gastroesophageal reflux disease, Barrett's esophagus, adenocarcinoma of esophagus, adenocarcinoma of cardio of stomach. It causes disease like 80% of the duodenal ulcer, 60% of gastric ulcer, carcinoma of the stomach, and maltoma. The virulence factor. The virulence factors. Flagella. The bacterial mobility. It is responsible for bacterial mobility and chemotaxis to colonize under mucosa. Urease enzymes. The urease enzymes neutralize the gastric acid. The urease present over here. It neutralizes the gastric acid and gastric mucosal injury by secreting the ammonia. Lipopolysaccharides. It adheres to the host cell inflammation. Host cell inflammation ಎಲ್ಲಿರುತ್ತೋ ಅಲ್ಲೋಗಿ adhere ಆಗುತ್ತೆ. Lipopolysaccharides adhere to the host cell inflammation. And this red thing over here is outer proteins which adheres to the host cell. And let's talk about exotoxins produced by the H. pylori. Exotoxins released by H. pylori, it inhibits CD4 T cells proliferation. And vacuolating toxin A and gastric mucosal injury. See, exotoxins inhibits the CD4 T cell proliferation, like vasculating toxin, produce vas, vax, vascule, vaxule, vasculating toxin A and causes gastric mucosal injury. Type 4 secretory system. The type 4 secretory system is a pile-like structure for infection of effectors. The secretory enzymes like mucinase, protease, lipase, gastric mucosal causing gastric mucosal injury. The host cell effectors are CAG-A, etc. They causes actin remodeling, interleukin 8 induction and host cell growth and apoptosis inhibition. Forms of gastritis are antral predominant gastritis causes duodenal ulcer, corpus predominant atrophic gastritis causes gastric ulcer or intestinal metaplasia which cause dysplasia then carcinoma. The non-atrophic pancreatitis causes maltoma, which is a main cause of extranodal marginal zone lymphoma involving B cells. Let's talk about dyspepsia. The dyspepsia is 75% functional. The symptoms include the postprandial fullness, early satiety, epigastric discomfort. These helpful in clinical diagnosis. Management is 2 weeks trial of proton pump inhibitors daily dose. The indications for endoscopy is more than 50 years, dysphagia and adenophagia, anemia, weight loss, mass per abdomen, history of carcinoma stomach in family. Investigations to be done to confirm diagnosis is endoscopy. For endoscopy, there should be epigastric pain. Symptoms of peptic ulcer. Epigastric pain should be nocturnal, recurrent episodes relieved on eating food and precipitated on fasting. Treatment for it is drug therapy. Before that, let's talk about endoscopy. If should be done if ulcer is present. Then H. pylori testing. Then you should give anti-H. pylori treatment. Rapid urease test. First endoscopy should be done in then antral biopsy, then urease test on the tissue sample. If positive, then there will be change in color. This is called as rapid urease test. Let's go to the treatment. Drug therapy. The first line treatment is 14-day regimen of OCA or OCM. What is OCA or OCM? O for omeprazole, C for clarithromycin, E for amoxicillin, and M for metronidazole. So amoxicillin 20 mg BD, clarithromycin 500 mg BD, amoxicillin 1 gram BD, metronidazole 500 mg BD. The second line treatment is OBTM. O for omeprazole, bismuth, salicylate, tetracycline, metronidazole. Note: other second line regimens are also used depending on antibiotic resistance of the area. Note: ACG recommendations is testing for H. pylori should be performed only if the clinician plans to offer treatment for the positive results. What is the approach to management? Indications of H. pylori treatment. Example: peptic ulcer disease or a new onset dyspepsia. Test for H. pylori. If it is negative, then H. pylori is not the cause. If it is positive, then give first line drugs. Wait for at least 1 month after the treatment finishes. No antibiotics, bismuth compounds or proton pump inhibitors in the meantime should be given. Then do urease breath test or stool antigen test. If it is negative, then any remaining symptoms are not due to H. pylori. If it is positive, then second line treatment should be given. If it is positive after second line treatment, then third line treatment should be given, which is endoscopy plus H. pylori culture and sensitivity test, and treat according to the known antibiotic sensitivities. If if positive after third line treatment also, then refer to specialist. Consider whether the treatment is still indicated.